Good afternoon, everyone, and welcome to PBA at noon. I'm Paul Benwell, and I'm joined by my colleague, Sophie Caesar. We are very excited to have MedX Health Corp, which trades on the TSX Venture under the symbol MDX. MedX is a global leader in teledermatology with its unique dermatological image capture technology and fully integrated telemedicine platform, DermSecure. The screening platform features high-resolution image capture technology that enables the accurate evaluations of moles, lesions, and other skin conditions, providing a complete virtual dermatological assessment by a certified dermatologist within just 72 hours. Today, we have with us President of Dermatological Services, Mike Druhan, who will update you on the company's progress on scaling global access to DermSecure. And I think Mike even has a very interesting personal story on the technology. Hi, Mike. Welcome back. It's good to see you again.
Nice to see you,
feel free to start your presentation, and we will have some questions for you at the end. Thanks again. Go ahead.
Welcome to be back. I think a lot of people have known about our technology. So what I'll do is I'll spend a little bit of time for those that are new to this site and give you a little bit about who we are and what we do. And then I'll spend most of the time speaking to our shareholders who have a sort of a burning question, where's the revenue? And we'll speak to that. And I also give a little bit of a personal story here as we move along. So we make a very declarative statement that we say we're the leader in teledermatology. And you're always at risk of saying that because everybody goes, well, if you're a leader, where's your revenue? And I understand that. And hopefully we can address that question today as well. So the normal forward-looking statements. Oops, sorry, I'm pushing the finger too fast. So to make a declarative statement like that, to say that we're a leader in teledermatology, I would say this: anybody who's going to make a claim like that, and I've been in this market for a while now, so I kind of know all the competitors and I know what's out in the market. These are the main attributes you have to make such a bold statement. So the first thing is you have to have a different image capture system than what's currently in the marketplace. Currently in the marketplace, most people are using teledermatology, are using these kinds of phones or cameras or snap-on tools on existing phones. The problem with those is they give very pixelated, very poor images. They don't give a clear image. And dermatologists are trained very extensively on a very fine image of a molar lesion. And if you're in a dermatologist's office, that's why when they put the little loop on you, they can look and they can see the fine attributes of a molar lesion or a pigmented lesion, and they can do a determination whether that's benign or needs a biopsy. So to give you a real number on there, and I'll come back to this as I go through the presentation, 42% of the images currently being sent across the internet to dermatologists cannot be read by dermatologists. Dermatologists look at them and say, it's either a Hawaiian island or a melanoma. I can't tell. I need to see the patient. So teledermatology's adoption curve has that barrier. We don't have that. We have a class 2 medical device, and our medical device gives perfect images every time to a dermatologist. We have a less than a 0.5% rejection rate from our images going across to dermatologists to be read. So our adoption curve is a lot higher because of our class 2 device. You have to be able to store the patient's information in a secure location. The images cannot leave country of origin, nor can the patient information. That's a very important piece of our build. The other one is the navigator system. We have to be able to get that image and that technology. We have to be able to get it, not only the dermatologist to assess it, but if it is a melanoma, get it to biopsy, get it to plastics to have it removed. All of that is built in the back end of our system. We have the most advanced, beyond a shadow of a doubt, back-end platform. So we have a fully secure back-end telemedicine platform called DermSecure. And we built that with the intensity that we would be an ERP, enterprise-wide platform, going across multiple locations. And we built it enterprise scale. And that's going to be a real important component as we move along into this year, because we're now dealing with some channels that are demanding the kind of security. So we're what we call SOC 2 type 1 security. which is the most advanced, because right now there's so much ransomware going on. If you don't have that kind of security system, you'll never get into the big players. And you can see we've made a press release. We're working with Empower going into the Rexall clinics right now. And we wouldn't be able to do that if we didn't have the kind of security background. And we're even moving into much deeper territory with much more secure environments we need to be in. And we've gone through all of those tests. And that kind of what they call pen tests and threat tests have to be at that SOC 2 type 1 level security. And MedX is well performed on all of that. We have to be able to store your information. We have to be compliant because we're a class 2 medical device, FDA, Health Canada. We're in 35 countries right now where we're eligible to go into and sell our technology or our offering. You should have peer-reviewed research. We do, and we have more coming. And you have to have the ability to have artificial intelligence, and we don't think decision-making artificial intelligence is the way to go. I'll speak a little bit more about that. And you better have a data monetization strategy. So with that, I'll move on and just sort of talk about how skin cancer and what's gone on. So one of the things that's happened during the pandemic, and this was one of the reasons we had a little bit of a real bad year last year in terms of getting to our market. Two things happened last year. The COVID was very real for us because most of the places that we go into are ease of access locations. And most of those were being tied up for either doing testing or giving inoculations. And that really slowed down our take up into the market that we thought we would get due last year. And what we did was we retrenched a bit and said, okay, we better make it that we don't have to be on planes and flying everywhere. We digitized everything in our service. So we can now drop ship our technology, do the training digitally, and are able to get people up and running rather quickly. So the onesies and twosies and things that you've been seeing a lot of press releases on lately, we can do those remotely all over the world, and we don't need to spend a lot of our human resource capital on that. But the melanoma issue has become a major incident. The delay times now for wait times to getting to see a dermatologist in Toronto, if you don't know anybody, or in some of the provinces, they're a really big time lag of about somewhere between 8 months to 2 years, depending on where your location is in Canada, to get in to see a dermatologist. And that's not healthy. Globally, the WHO put out a report that said 70,244 melanomas were missed because of COVID. And that's people that we knew had melanoma and just couldn't get in to get their appointments and dealt with. So that's a pretty staggering number. Problem with Canada, and I'm just going to focus on Canada just to talk, there's 537 derms only in Canada, serving 37 million people. So your wait times in Canada are anywhere between 5 and 18 months. And that long of a wait time, if you have a nodular melanoma, that'll kill you in 11 weeks. You're dead before you even get to see the dermatologist. And that's not a good system. So we turn that into a 72-hour time frame to have the same consultation as if you were in front of a dermatologist. This year, we beefed up our medical advisory board, and that has brought up some very good results to us. We have our standard medical advisory board, that's our sitting board, but we also have an extended advisory board. We've been very fortunate with that. We've had 4 different meetings with our medical advisory board in North America. We've had the top 10 dermatologists in the United States and the top 10 dermatologists in Canada from all walks right across the country. Some academic, some clinical, some specialty needs dermatologists right across. And all of them got in behind us to say, here's the best go-to-market strategies. We were very fortunate with the one we just did recently in Montreal that opened up the Newfoundland market to us. It opened up New Brunswick, opened up Saskatchewan to us just because of that meeting. So we've been very, very honored to have the medical advice we're getting, and we build all of our technology with the advice from the dermatologists about what they need as a product. This is the current technology state of the union. The top screen is what we call a dermatoscope. If you walk into a dermatologist, the dermatologist puts this magnified light on you. You can see this blue-gray veil here. That's an early warning sign. It's got radial branching. The whole sort of thing leans itself to say, well, that's suspicious. The dermatologist would immediately cut that out, and after a biopsy, that would be a melanoma, and the dermatologist can do it. That's a dermatologist sitting in his office. When you start to move to remote cameras and imaging technology, the problem is when you do the compression to put it across the internet, the images start to look like this. And it's really hard for a dermatologist to make any sense out of what these are. And normally that's why you have that 42% failure rate on the images going across the internet currently. This is our technology. It takes this type of image quality. So this is one that I caught. People have heard this story before, but this is, I'll sort of just talk about it for a minute. But that was a suspicious mole on a back that I saw at a golf course. This is featured on our website. This is what it looked like. This was seen by a GP 3 times, and all 3 times the GP said it was nothing. So the GPs are not really great at determining what are melanomas. Our technology gives views below the skin. This was a single mom with a daughter with cerebral palsy, and I was able to locate that and take it out. Just on a quick note, about a week and a half ago, I'd come out of the shower. Not that you all need to hear that, but anyway, I was on the bed and I was typing something, and my wife walked by and noticed that I had something on my back that was black and suspicious. Took a picture with her camera, and I couldn't make anything out of it. And of course, I have the scope on me at all the time, and I was able to scan it. And it turns out that I had it. No, we don't know. It hasn't been back from biopsy, but it was suspicious enough that we ended up sending it over to the dermatologist, and he said, "Let's get it in." And I had a biopsy last week, so I'll know in 2 weeks what it was. But you know, it was kind of talk about surprise, because I'm always checking everybody else, and all of a sudden my wife caught one on me. So I'll let everybody know an update on that one. But it sure makes me pay attention to this technology. This particular melanoma was one that was on a lady. She was 40 odd years old, and she noticed this on her. And this is called a nodular melanoma. And this is the scariest of all melanomas. This one can take you out in anywhere between sort of 11 weeks to a few more months out than that. This is fast growing. It goes vertical. It gets into your bloodstream, and it goes metastatic. And it's the size of the end of a piece of a pencil or eraser. But you can see with our technology, not only does it give a very clear image, but it also allows me to go below the skin and see the attributes below the skin that are showing that this is going vertical. This needed to come out straight away, and we were able to save that person before anything happened. Oops, sorry about that. Let me just take a second. Sorry, I'm ripping through this. The other thing we built during the time off, sort of with the COVID and that, we had a lot of commentary from our medical advisory board saying, it's great that you can do contact dermoscopy on the skin, but we also need for you to provide for us a secondary image, an image around the molar lesion, so that we can get a better understanding of the clinical surrounding area. So this is the Scioscope, and that's the aperture, and it goes directly on top of the skin. So you've got a fixed focal point, controlled spectrophotometry in there, and that's a class 2 medical device. But what they really wanted to see was a camera that had the ability to take a different type of image. And we built this camera, which allows us here, it's got a very interesting light source, and it's got a really rapid response on the ability to take a clear image. And this allows us to deal, if you think of the market as pigmentat lesions being things that can kill you, but it allows us to deal with everything else. So now we have another whole vertical market beyond the pigmentat lesions. We can do psoriasis and rosacea and tropical rashes and any of those other inflammatory conditions. So we're working our way into a digital dermatologist in the box that can provide all the imaging that a dermatologist needs to make a proper assessment. We have our full patient management system that allows us, and this is a big part of our digital monetization policy. So we have a lot of information about the patients, a lot of it's anonymized, but because we take such high quality images, that data library, we're starting to work this year to put a monetization strategy together so that we can work with that. So MedX now stands like this. Currently, we have our pigmentat lesion vertical market. We're well the leader in that space, and that's a space that nobody else can really move into and touch like we can without a class 2 medical device. So you'll notice if you go on any of the other apps, They'll talk about things like rosacea, acne, and stuff like that, but not a lot of them are on there dealing with pigmented lesions. So we can quite easily handle the stuff that'll kill you, the melanomas and the more pigmented lesions. Now with a secondary camera, we can do the inflammatory conditions, which is the acne and rosacea. And now about halfway through this year, we're working right now on a wound management and a group of wound management people. We will build a wound management pathway. And that allows us to go into the old age homes and things like that. And of course, COVID has just ravaged those areas for pressure and diabetic tumors and things like that, because they're not allowed to leave their rooms. They're not getting rotated. There's getting all kinds of blood blisters and things like that. So we'll be able to build a patient pathway where we can go straight to wound management. And our technology works excellent there because the Scioscope allows us to look at below the skin to see any of the topical treatments that they're giving patients like that, if they're getting restoration of blood supply and collagen breakdown, and it gives them a lot more information than just a visual picture. So we're looking forward to that market, and we've got some good plans for that. So our AI strategy, we work deeply with Dr. Trevor Champagne on this, and the reason we do that is Trevor is not only a dermatologist, but he has a full background on computer science that he has. So he has a good understanding of math and computer science, and he has a practical flow on where AI should be used. And we think a lot of people are trying to use AI as decision-making software, and we think that's a false start, because if we start making patients where we say that we are making a declarative statement that this is a melanoma and it's not, or it's not a melanoma and it is, that's just a lawsuit that'll put us out of business. We're not in that business, but what we are able to do is get much more effective flow strategies for the dermatologists and yield management. We can guarantee when we send an image, because we can look at the AI and the AI will tell us whether the image is fine to send to a dermatologist, that it's guaranteed. And there's a lot of real world problems we can solve with our AI platform. And we're really honored to be working with Dr. Champagne on that, because we just filed a patent the other day. So there's 2 other patents we've got working on right now. So we continue to build our provisional patents and our IP base there. So the way it works now, we'll get to the math side with the money, and then I'll open it up for some questions. The way it works is we have 2 sort of ways we do the device. The hardware itself, which includes the laptop, the Scioscope, and the camera, we can rent that or lease it, and we do it for about $200 a month over 5 years. And that's a $12,000 lease up front. We're working with a lease company where we get paid up front for that. We know what our COGS are, less than $2,000 on that. And we're getting the hardware revenue of that at $12,000. And depending on which market we're in, we're getting between $10 and $30 USD a scan for what we call an e-consult. Patient goes in, gets a consult if they're using our technology, and it's going across the internet, and we're storing the patient's information. Every time a patient does that and it goes to a dermatologist, at that moment in time, depending on the environment we're in, we're getting between $10 and $30 per consult. And the other big thing we've done, and I'll just see here. Okay. The other big thing we've done, if people went in to look at our announcements, we changed up a couple of things, because when we first started into this, like a lot of new companies, we really didn't have a good understanding of how to get into our markets, what was the best way to go at them, how do we target the clients properly. With the addition of, and it was really Naman that came in from from Medtronics and brought that discipline into us, he started to insist that the way we were going about our markets was incorrect. So as the team got together, we started to see, and you'll see a lot of press releases of this most recently, he said, we need to pick our targets very carefully. They have to represent a particular market channel strategy. They have to be able to start with a pilot. So with all of our people that we work with, we do a pilot first. And the reason we do that, these are commercial agreements with the MOU that they will agree in 30, 60, 90 days, depending on how many markets and the size of the market. We'll do a 30, 60, 90-day trial, pilot trial with them. They pay for the hardware, they pay for the scans. Most of them are between 600 and 1,000 patients go through. Meanwhile, they'll come back and write us a full business plan, and they'll say, here's how we're going to the market. And we build out a pricing model from there and move it into commercialization. So what we've been seeing is we're getting much better at targeting real clients that either have a large constituency So we're really looking at the increase in patient base. So if you take a look at the Empower deal, that we've been very lucky to work with them with their centers, the one we did in Long Branch, that has a 10,000 patient roster that we can go into that patient base. Those are all the doctors there know about the technology. They've got a separate room there that's got a marketplace that can't get to dermatologists, and it's got 10,000 captive audience that can come through our system. That's a very good market model for us. We did a deal over in Italy, and Naman's not in Canada right now. He's back over on that side meeting with that. We've had a very successful pre-pilot trial with them, or pilot trial with them, and we're working to go to commercialization with them. I will say we are working very hard with a large occupational health sector, and we're looking to do that. And that's where the enterprise scalability of our technology will put us ahead of everybody. And hopefully, when we put this out as an announcement, the shareholders will see that we are of enterprise scale, and this is a much larger captive patient database that we're going to be able to serve. So all in all, this year, what we're trying to do is get to the cash flow positive. We've said to our shareholders, and we're on target for this, that we'll get 158 scopes out into the market in the first quarter. So one of the things you can expect for us now is we're going to improve this, but we've got right now a map on our site which says where can I get scanned. We're starting to populate that map every time we add on new locations, and you'll be able to see how many locations we open up every quarter, and you'll figure out, okay, with each location they're making between $5,000 to $12,000 on those locations, and you'll be able to figure out, the scan revenue, because we'll say how many scans we're doing. So shareholders will get to start to see the revenue curve without having to wait the extra 3 months for for that to come out. I think that's 20 minutes, Sophie. Just on this side of it, you can expect, and you've been seeing this since November 17th. We've been making announcements after announcements. And I'll just finish on this. Some of those announcements that you see with us are, smaller 20, 32, 3 type of announcements. But some of them, like the Al Zahari group in the Middle East, that's a really big, that was a 6 months of them doing due diligence before they put us on top of their roster. And we expect really big a growth out of that area. So some small, again, proof of principle, proof of concept, but others that we're working on now are much bigger. So I think that over this year, we'll see a very profitable year for MedX. And I'll leave it at that there, Sophie, and then I'll answer some questions.
Thanks, Mike. I think that's actually a really good point that you just made, that I don't think sometimes shareholders don't realize that when you sign these contracts, there's been months of due diligence being done by the other party, which I think just, reinforces your technology, the company itself, and your team.
Yeah, we're working on one right now that has a captive patient base of about 2 million. And it's been 6 months of due diligence, and I'm really proud to say the tech deck that we had to put together, that we withstood that kind of brute force interrogation on the due diligence side. And I've been in on these things, and I know what we have to go through. And it makes me proud that we can withstand that, but it also lets you know what our barrier to entry is for enterprise scale. And so I think that'll make a big difference here. People will start to see that. And of course, once you get a big captive audience like that, it's hard to get knocked off the block if you're doing your job right.
Exactly. So we have quite a few questions, but I think one of the questions that really that's come up a couple of times here in the chat and in the Q&A. So you are global, but where is your focus right now?
It's a great question. So right now, the Canadian market, we're really opening up. The one piece I didn't answer that I promised I would do, and I forgot to do, was Quebec. So Quebec's been driving me crazy for anybody who knows me for years. And the problem with Quebec has been this. We haven't had, up till now, any way of getting to the dermatologist because there were no codes for the dermatologist. And just last week, the Dermatology Society, RAFQ, they put out a guideline for the dermatologists. Now, the great news is we've been working with the top dermatologists in Quebec for quite some time now, at the Jewish General, at McGill, and in Quebec City with Joseph Clavel, and they've been on our medical advisory board. All of a sudden last week, Quebec came out and said, we're going to allow for teledermatology where the dermatologists get paid, and they get paid $69 to review a consult. And that's really
Wow.
good payment for them for something that takes them maybe 2 to 3 minutes to do. And so, of course, our phones started to light up and we were like, oh, great. Now we've got to go out and populate that area. But I'm really excited about that. So big focus in Canada because we've got a couple of opportunities here that are scalable. UK will be the next really big area of concentration. Italy will come on side, the Middle East. Brazil's starting now to come out of after the COVID, and
Yeah.
we're really working. The team's doing a good job down there. We're starting to see them light back up, which is really nice. We're starting to see scans, and we're starting to see them get back to the market. But Brazil got hit pretty hard with that. But I think the big one will be the second half of the year in the United States. We've got a very strong strategy for moving into the US market. We're partnering up with some big names down there. You know, we can't go into the US market as a little company with MedX. I'm at a card table with a trade show, you know, waving a banner. You really do need to partner with proper size and scalable people for, you know, right across the country. And I will say we're working with some very scalable people down there right now. So we, you know, that'll take us to mid-year, but in between now and then we'll have a lot of the stuff that we've been sort of working on will start to convert from pilots to that, and people will start to see an acceleration in the markets we're in right now.
Excellent. So you did touch on Brazil. How many locations do you have in Brazil and Mexico?
So Mexico was, I'll pull them aside separately, the Brazil. Last time, my understanding was, I think we're up at 41 locations up. I know that was the number that I heard from the guy, our partner heading the US or the Brazilian side. I think 41 are up. I talked just before I had this speech that said, are they starting to getting some scanning revenues coming through? And the answer to that was yes. And so I think Brazil has a different business model than the Canadian and the other models, because they're going to the market with a pilot, like a bigger reaching pilot first. But we're really starting to get some traction. Our partner down there, Carlos, has been exceptional. And but boy, during that lockdown, I mean, if anybody's been to Brazil, I mean, that country was devastated with this, and now that they're getting a handle on it and the virus seems to be running its course, and that I'm looking for bigger things in the second half of the year with Brazil. Mexico was one that the honesty of it was we were working with our partners, the COVID hit, and by that time we had what we thought was a great partner moving into that thing, and they were busy, and we just didn't really have that sync up. So it's an area where right now I don't have a big concentration in going in. So I think Mexico, we've taken kind of off the mark, not for any other reason, just we're thin, we have to stay deeply focused, and we have places where we're getting really big traction without having to be with a barbelled economy where you've got really poor and really wealthy. It's harder to get at. It's better to go into areas where you know you get easier acceptance. We've got the dermatologists on side. You know, the UK is a big market for us. You know, so that would be the answer to that.
So you touched on COVID. So how is the supply chain working for you guys with, I mean, you know, we hear that it's in a global issue. Are you having any problems with that, with the inventory of the wands?
Well, we were fortunate that we built up some supply, we built up some inventory so that we could handle the current demand. The other side is the bigger parts for us is trying to get things like lenses. And unfortunately, the lenses are made in Germany and, believe it or not, Rochester, because Kodak was there. So those aren't areas where we're having as difficulty getting in the parts as we are, for example, if you're trying to get it out of China, where you've had shutdowns and you've got all trade and all of those sort of people standing in front of you. The one things that you are catching going on is with certain computer chips, and we're seeing this as a global phenomenon, but that really hasn't impacted us. We're okay to get our stuff so far, you know, knock on wood. And as it opens up more and more, the one big thing that it does change is that, you know, if you were saying, let's say you had an order for 100 scopes or something like that, and you said, oh, I need 100 of these chips, the marketplace says, no, you have to buy 10,000 or we were waiting in line. So that's so smaller companies are suffering from they're suffering more from things like volume, that they have to buy in volume if they want to get a place in line. And we haven't had that issue now, but we've got to, you know, we've been doing this for a while. So our production people have got, you know, they've got their tentacles everywhere for the production. So we won't have any problems in being able to supply.
Oh, that's perfect. So, you know, you're building this, you have the system and you're gathering all this information. Is the database itself, do you hold on to that? Is that generating any revenue, or are there plans to make that work?
So the biggest part of our wealth creation as we go along will be the data. The data monetization. So we're going to work really hard to get that data monetization straight. We're going to add somebody onto our organization that is a data monetization specialist. That'll be coming shortly. We're just working through that piece now. But here's one of the things we can do. Because the problem with images, if I'm taking images with a camera that doesn't have a fixed focal point, and I'm shooting it from different angularity and different light, those images are really hard to use any kind of artificial intelligence or clinical research to it. If I'm using the Scioscope, because I've got a sealed unit and I've got a fixed focal point, the images are perfect every time. And what that allows us to do is build a clinical library of every kind of disease. So if I'm a researcher, I can draw down those images for research purposes, and there's all kinds of data monetization I can do with there. So we're very excited about the data collection that we have right now. And that's a strategy that we'll have. You'll probably see that in the latter part of the year where we start to articulate out our data monetization strategy and get revenue from that. But we've got over now, I think we're well over 10,000 images in our database, which is, but the real-time images. So, you know, this is so a lot, anybody who knows AI and stuff like that, garbage in, garbage out. So all these sort of meta universe data, it's useless stuff because it's not the same time.
Okay, I see Paul's popped on. Paul, do you have a question or two for Mike?
Oh, you're muted.
Oh, you're muted.
Can you hear me now?
I can hear you perfectly, Paul.
All right, perfect. You had a press release this morning about you're moving into New Brunswick.
Right.
Can you touch on that a little bit? I mean, is this a big project? Or is this going to generate some good revenue?
What's interesting is the first time I would say we've had this in a long time. We're getting inbound calls now, which I would say MedX hasn't had, you know, since all the time I've been here. We're starting to get inbound calls. This was an interesting opportunity. Paul Zeimer down, you know, Paul Zeimer's really been great because he's doing a lot of our clinical integration. We've been really blessed to have Paul on our side. And he worked down in New Brunswick, and what he came to me back, he said, wow, this is really interesting because not only is it a stationary one, and not only is the wait times forever, but there's a mobile unit to that. And that doesn't sound particularly interesting, you know, as a onesie, right? That you can reach to outreach to patients, but that is something that keeps you very busy. And we really liked it because we're working right now with another very large install that has lots of standalone clinics, but they have 27 mobile clinics as well in a captive audience base. And that's very appealing to us to be able to see if there's any challenges with the mobile units, because there you're using hotspot. And now I use hotspot all the time, and we're able to connect because we need an internet connection with our device. So it's great to try that in New Brunswick. And it's great because, you know, it's a big province if you've driven through it, which I did last summer. And I can assure you, there's lots of remote communities. So now you can go into these remote communities, set up for the day, and give people the same healthcare provision that you can give back to in a populated city. So you get this high intensity where you go in, the population comes and shows up, you get an instant access to a dermatologist, you can get everything handled, and then it goes away. So it's an interesting way to go at the market.
Do you sponsor any of these mobile clinics, or is that like the?
It's all we don't. No, that's the distributor's responsibility. We don't get that granular with it. We hand it off to them and let them do it. Now, we have done stuff with the Melanoma Network of Canada in the past, and that was more for getting our awareness levels up. Problem was we had an awareness level, but no place to go. So kind of like a dog barking out in the woods. Nobody really cared. So now as we get more and more along here and we get more and more locations across the place where we can say, go get scanned, now we'll start to increase our awareness campaigns that we can do with organizations like that. But I've done, you know, we did one for the Melanoma Network where we scanned 90 people after they did a 5K run. I got to tell you how much fun that was. You know that one. So, but we did
I would know that one.
Yeah, you would know the 5K run.
Yeah.
So they did a 5K run and came back, and it was about 103 degrees. And I stayed out for 3 hours with one of our dermatologists, and we scanned everybody. But it was a good community service event, an awareness event, right?
Yeah, very much. It's prevalent in for runners, triathletes, because they do so much training outside. So I know it's an issue.
Well, I can quote the numbers in the UK. Right now in the UK, outside construction workers had 3,000 patients that were deemed to have cancer from being outside and working. So imagine you can go into a market like that and have a way of getting at those outside workers. So occupational health is going to be, I think, a big piece of our future vertical market where we can go at a lot of people and we can reduce the, I mean, and think about it, a melanoma caught if you're an occupational health insurer, if you catch it at stage 1, it costs you $1,400 to $2,000. If that gets to stage 4, you're $1 million with that same with that employee. So it's a big savings for there. So that's a big vertical market that we hope to dominate.
And touching on that, Mike, do the provincial governments allow, like, do they discount your, what am I trying to get at?
I've got the question. I know exactly what you're asking.
Do insurance companies cover it?
So let me go with where that is, because that one was a real hesitant point. So it was interesting. I was out with Dr. Max Sumner, who's the top dermatologist, or one of the top dermatologists at Princess Margaret. And I said, I'm having such a hard time getting my, and he goes, oh, there's one person you have to call, Tracy Lloyd Termaine. She's the expert on this. So we called her. And she said, and we've got the opinion paper, and it came back, and it was basically, here's how it works. GPs are insured under the Health Care Act. Okay, so that's taken care of. So they get paid for the consultation. Dermatologists get paid for reading it, which we just saw happen in Quebec as well, but all the provinces have that. The part in between is an uninsured part. That's us. So we're allowed to take the information, take the patient scan, and from the GP over to the dermatologist and charge a fee for that. We're well within the legal bounds of everything to do that. That's not a problem. That's absolutely fine. So now the dermatologist, we can give them the letter. This is a legal opinion letter from the top, for the one they use for all of their legal opinion letters. That's we're not causing any trouble on either side of that fence. And that was something that was very concerning to me, because you always want to work with your healthcare partners. So we weren't one of these ones that all of a sudden threw up a cheap site. We've been at this for a long time to get it right. So the next part will be, once there's enough data collected, Paul, at that point in time, the insurance companies will start to add it to their health spending accounts and things like that and say it's just taken care of. In the case of a employee benefit plan for a health insurer, they will just include it as part of the service that they offer. So we're getting a lot more traction that way here and in the US market as well.
Yep. A couple of quick questions, then we're going to wrap this up. Do most dermatologists take both equipments, like the new camera and the wand itself, or do they have to have both, shall we say?
Well, the answer to it is they prefer it. The reason why is they get a contextual picture around the molar lesion. So this camera is really interesting, the HD camera, because we can take the whole back and show them the surrounding area, or we can go right down to the size of your fist around it with a dime in the middle, which is the mole. And they really prefer that because they're used to seeing contextual information. That's how they've been trained. So they really like that, the additional view with the camera. It just gives them more contextual information. So that's going well. The other side is, I think the number was something like 26% of the pharmacy scripts that are written, believe it or not, are written on the skin. It's the largest organ on your body. So so like, think about rosacea and acne and all the sorts of things. So that's it, right?
All right. Mike, it's been great getting you back again. I mean, this should be the year that really things start to come into place. COVID is easing up. The world is reopening up. I mean, people are, like you said earlier, people have missed diagnosis because they couldn't get to a clinic or it was shut down or whatever. So hopefully this is going to be a great year for you guys. And there was one other, could you get a bit? No, that's we covered.
There was one, we covered that. Yeah, exactly.
Yeah, we've covered everything.
That was
Mike, great to see you again.
Thanks,
once
Paul.
we
Nice
get
to
really
see you.
open up here, we're going to get you to Montreal and put you
To
in front of some
Montreal,
people.
and you can break into the Quebec market. It'll be great to have you back.
Well, you know what? We got some really interesting talks going on there. So as soon as I do that, it's like, can you come up and talk? Try and stop me, because it's the market I've been dying to get at. So the interesting side of the Quebec market, it goes like this. It's sort of like 23% of the Canadian population, as high as 40% of skin cancer deaths. In the outlying regions, and I've traveled around, and when I need to get in and make sure that doesn't happen. You know, I mean, I'm a little crazy that way.
Yeah, we like our
So,
sun here, so we get so
yeah,
little.
well, yeah,
We
yeah.
get so little of it that we end up going outside and not taking the proper precautions.
Well, the
so.
southern tip of Quebec is Miami or Florida. so,
Yeah, it's
so we
true.
know how it works. But listen, thanks so much for having me. For all those shareholders that have been patient with us, I can assure you this is going to be a much different year for MedX than the previous years. And I would say that we've got a really devoted team to drive in sales. That is our single focus. And I think everybody's going to continue to see lots of news releases, some small, but a lot of them coming out will be much more meaningful. Thanks for
Excellent,
your
Mike.
time. Okay.
Thanks again for your time. Appreciate it. Thanks to everyone who logged in today. We'll keep you posted on any news that's forthcoming. Take
Okay,
care,
so
everyone.
much.
Thank
See
you.
you, everybody.
Thank you.
Cheers.
Thank you.